Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Hello, I'm Dr. Anton Pozniak. I'm a consultant physician at the Chelsea and Westminster Hospital in London in the UK. And so welcome to Clinical Clips. And this is from Glasgow 2024. It's of day 1 of 2. And I'm going to cover today 2 long-acting therapy studies as well as a dual therapy oral study. So we had a very good plenary by Professor Jose Arribas from Spain on long-acting therapies and where they're going. Today, we heard about the phase 2 open-label study, randomized 1-to-1, to continuing BF-TAF daily or to switching to these islatravir, lenacapavir oral therapy, which was given weekly. Now, the inclusion criteria, because we've had this signal in the past about islatravir and CD4 count and total lymphocyte count going down on some of the dosing, they included patients who had a CD4 at least 350 cells and lymphocytes at least 900. So, these patients have started off with good lymphocyte counts. So what about the results? Well, they were very good indeed, 94% versus 92.3%, the len with the islatravir versus the BF-TAF. And the other thing was there were no virological failures, which was defined at greater than 50 copies at week 48. There were some discontinuations in each arm, 3 in each arm, but none was study drug related. We also saw the CD4 and lymphocyte counts, which stayed flat on these doses. So the other issue that came out of this was the PK of the islatravir, because people are, and this was presented in a poster, and people are concerned that islatravir can generate in vitro the M184V or I mutation, and in fact the PK of the islatravir at this dose, the triphosphate, was high enough to overcome any sort of mutation. So overall, this study was very encouraging, and it's moving on now to phase 3. We'll get 2 big phase 3 of the lenacapavir islatravir, and this will take another 1 or 2 years probably before we get all the results. But it's really encouraging that we've got this weekly therapy, which, as I say, in some of the surveys in the past, patients prefer. Now, the other long-acting therapies are the monoclonal antibodies. And why have they attracted such news? It's because you can give them 6 monthly. And also injectable lenacapavir, as you know from the prevention studies and other studies that have been shown, you can also inject that 6 monthly. So now we've got synchrony between more than one drug that's injectable and long-acting. So we saw the individual data of the monoclonals, teropavimab and zenlirvimab, lovely names, but very well known as TAB and ZAB. Now, the presentation today was looking at the pooled analysis out to 26 weeks of these 2 monoclonal antibodies given with lenacapavir. I just need now just to give you some of the background. About 50% of isolates, clade B isolates looked at will be susceptible to both TAB and ZAB, and to one of them, either TAB or ZAB, about 90% of isolates. And in this study, 2 different doses of ZAB were given, a 10 milligram per kilogram and a 30 milligram per kilogram dose. And they divided this data now. They pooled the data of the people that were susceptible to both or susceptible to one. They pooled it and then divided it into 2 groups, those that were on the high dose ZAB and those that were on the lower dose ZAB. Interestingly, 3 patients developed viral load of greater than 50 on the low dose ZAB and none on the high dose ZAB. Now, out of those 3 with the viral load greater than 50 who are on the low dose ZAB, one of them developed a mutation to lenacapavir, the Q67H, which is a significant mutation. And interestingly, that patient was susceptible to both TAB and ZAB. The other interesting thing about these therapies are that you can get infusion site reactions, of course, and with the lenacapavir, there were some injection sites nodules and injection site inflammation. So what's going to happen with monoclonal antibodies? They are going to be looked at more now in phase 2 studies, and we're going to see the higher dose of the ZAB used. Whether or not they're ready for prime time, I'm not sure, because of susceptibility testing. How reliable is it? The infusion and the issue with the burden on clinics, although it's every 6 months, and also this clade B problem, which won't really cover all of the world. And I don't know how expensive they're all going to end up being. But the science is behind them. Let's see how this all progresses going forward. Now, let's move tack to dual therapy. And one of the dual therapies that many of us are using, mainly in switch rather than start, is dolutegravir together with 3TC. So Pedro Khan, who has been fantastic in researching the dual therapy from the very first studies, has performed another study with Argentina and Brazil as the chief investigator, looking at dolutegravir 3TC versus triple therapy. Triple therapy, most of it obviously will be dolutegravir with TDF and 3TC in patients whose CD4 is less than 200 and a viral load more than 1,000, but there was no upper limit to the viral load. Obviously, there had to be Hep B negative. Now, what about these patients? A third of them were category C, WHO, AIDS category. 25% were women. The median CD4 when they came in was 116, and that's the percentage CD4 was 8%. These are very advanced patients. Now, what about the results? And as I say, this was not a non-inferiority study. It was an exploratory open-label study. But the results, if you look at the ITTE FDA snapshot result, was that dolutegravir performed in less than 50 copies at 48 weeks at 82% versus 81% in the triple therapy. Now, interestingly, if you pick it apart a bit, which Pedro did, when you look at the success rates at over 100,000, over 500,000, over 1 million, it decreased. So when you got to 1 million, it was 63% on the dolutegravir versus 57% on the triple. No major difference between the two, but much lower. As far as the side effects, they are very similar, less than around 1% for treatment related. But one question, of course, is what about iris syndrome? As you know, people with high viral loads, low CD4 start on therapy, and the rates of iris were around 6%, which is about what we've seen in other big randomized studies of those who start with low CD4s and high viral loads. There were some deaths, which you'd expect in this population, 2.6%. So overall, it's not a non-inferiority blinded study, but it does add to our evidence. And actually, dolutegravir 3TC can be used in those with low CD4s and high viral loads. Whether clinicians will adopt this and say, well, I still prefer to start with triple and reduce down to 2 drugs, even with this data, we'll have to wait and see how that goes forward. So that's day one of the Glasgow 2024. Thank you for joining us today on day one. And please refer to the landing page for slides and to claim your continuing education credit. And be sure to come back tomorrow for our second clinical clip from Glasgow 2024.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.